Good morning, everyone. My name is Jaime Vinck, and I have the honor and privilege of being the Chief Executive Officer for the Sierra Tucson Group. The Sierra Tucson Group consists of Sierra Tucson in Tucson, Arizona, Sierra by the Sea in Newport Beach, California, and Sunrise Ranch in Riverside, California. All of our programs have all levels of care, as we know the importance of continuity of care. And we all are supported by Connect 365, which is 1 year of continuous aftercare. So this morning, what we want to talk about is compassion fatigue and provider resilience. A couple of years ago, when I was Chief Clinical Officer, I spent a great deal of time researching this topic, became a certified compassion fatigue therapist, and did a lot of presenting across the country and here at Sierra Tucson on provider resilience and compassion fatigue. Over the past couple of months, what we've been doing is working on ways that we at Sierra Tucson can be of service to our colleagues, those of us that are at residential treatment centers and hospitals still working, and those of us who are working virtually. What we did is look at all of our presentations, adapt them, and decide which ones would be useful to all of you, and it is our honor to share this information with you. I took the presentation, Compassion Fatigue and Provider Resilience, and I've adapted it for virtual, and I'm also calling it Now More Than Ever, because this is just so critical that we are all taking care of ourselves and taking care of one another. So I'm going to switch it over to the slides, and once again, thanks so much for being with us today. The expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic as expecting to be able to walk through water without getting wet. This morning, our goals for training are to understand the elements of compassion fatigue, to discuss moral injury and why that's so important and so prevalent in our COVID-19 world. We're going to talk about how to build our own provider resilience, how to embrace compassion satisfaction. We're going to talk about the ethics of self-care, and we're going to talk about some solutions for both individuals and organizations. We know now that between 40% and 85% of all helping professionals will develop vicarious trauma, compassion fatigue, and high rates of traumatic symptoms, according to our compassion fatigue experts. We know that social workers, in particular, report that 70% exhibit at least one symptom of secondary traumatic stress. And for those of us that work with sexual assault, 70% report vicarious trauma. Now, this is especially interesting because for those of us that work in the addiction space, we know that the stories of sexual assault are extremely prevalent. And this statistic was a wake-up call to me to think more about the vicarious trauma that we're all experiencing when we work with those struggling with a substance use disorder. So what is compassion fatigue? That's something that people talk about very frequently and give it a number of different definitions. The one that I like the most is the profound emotional and physical exhaustion that helping professionals and caregivers can develop. It is the gradual erosion of all things that keep us connected to others in our caregiver role, our empathy, our hope, and our compassion, basically the things that make us good at our jobs. So compassion fatigue is really a physical and emotional reaction to hearing another person's trauma. And if we drill deeper into it, what we see is that when we combine secondary traumatic stress and vicarious trauma and burnout, we come away with compassion fatigue. So let's talk about what each of these items are specifically. So secondary traumatic stress is rapid onset and associated with a particular event, and the symptoms mimic those of post-traumatic stress disorder. They include being afraid, having difficulty sleeping, having images of the stressful event, and avoidance. It's very important for us that are practicing to know our triggers, to know what secondary traumatic stress triggers that we have, and watch the things that we are doing when we're around one another as clinicians that can potentially be triggering. For example, there's certain phrases that are extremely triggering to people, such as committed suicide rather than died by suicide, or mocking a gunshot any place, but especially to the head, or mocking a hanging, those kinds of things. It's amazing how prevalent they are and how many really savvy people still will do those symbols to communicate. My own personal trigger is when someone will say, I don't want to beat a dead you-know-what. That is something where I can find my trauma will be activated just immediately. And Arizona is horse country. And if you want to see a trauma response in a room, use that expression. I think it's very important when we will talk about being a trauma-informed organization, but please think about these kinds of things. I did this presentation in Colorado one year, and a woman came up to me and said, "Thank you so much for saying this, because my expression that triggers me is the rule of thumb," because that's something that was previously used to talk about how big the stick was that someone could beat their wife, and that's very insensitive to domestic violence survivors. So we simply don't know. So it not only is important that language matters, but also it's okay to set your boundaries around these things. Vicarious trauma, on the other hand, is a cumulative process. This isn't the worst story that you've ever heard, but it's the impact of thousands of stories that you may not even remember, but they're there. You're carrying them with you. The difference between secondary trauma and vicarious trauma is that secondary trauma is rapid onset in one session, while vicarious trauma is the response to an accumulation of an exposure of the pain of others. Over time, vicarious trauma actually creates covert cognitive changes in our brains that can impact our worldview. The best description that I've heard of to explain vicarious trauma is the old frog in a boiling pot of water. If you have a boiling pot of water and you throw a frog in there, he will immediately pop out. If you put a frog in room temperature water and turn up the heat, they will stay in that pot. So it's very important that we understand the freeze dimension of our vicarious trauma and when we are in that state of freeze. So what happens in vicarious trauma? Our self-capacities, our identities, our relatedness, our ability to tolerate and integrate is diminished. The dysregulation and loss of ability to self-soothe. And we'll talk in a bit about self-soothing and the self-confrontation and the role that plays in our resilience. But when we're suffering from vicarious trauma, it's just not there. That increased self-criticism and the inability to respond to the needs of others or even to seek support for ourselves. That's what happens in vicarious trauma. It's really a shifting of our worldview and the loss of who we are. So burnout is a different thing. Burnout is the psychological symptom of emotional exhaustion, depersonalization, and the reduced personal accomplishment. So burnout is really more about the organization than the individual. It's the chronic conditions of perceived demand outweighing perceived resources. So Your insurance person can be burnt out. Your car salesperson can be burnt out. Burnout is a reflection of an organization. To look more at the symptoms of burnout, it is emotional exhaustion, feeling depleted, overextended, fatigued, the depersonalization, negative and cynical attitudes towards our clients and our work in general, reduced personal accomplishment, the negative self-evaluation of one's work with our clients, and decreased effectiveness. I see this manifesting in a couple of different ways in our environment, because we all know that there's never a case where we're burnt out and there's not enough resources to go around, right? In behavioral health, I'm being terribly sarcastic. I see this, however, when we get someone will say, "Oh yes, would you see the borderline?" Or what about the person, the chronic relapser? They've been here 5 times. Why do they believe that this will be the thing that will do the trick? And I do believe that those are huge indicators of burnout, because we all know that it doesn't matter how many times people keep coming back. You never know when they're going to get their miracle. So these are things that I keep a lookout out for in our team. So the key differences in these, they're similar, they're different, but they're complementary and often used interchangeably and incorrectly. This matters because we need to know the differences in what we are dealing with, because then we won't just treat the symptoms, i.e. the maladaptive coping strategies, or the construct of being, meaning I no longer trust. So compassion fatigue, profound emotional and physical erosion when we can't refuel. Secondary traumatic stress, bearing witness to a traumatic event which can lead to PTSD symptoms. Vicarious trauma, that transformation of a worldview due to cumulative exposure. And stress and frustration caused by the workplace. So in the days of COVID-19, I have seen the concept of moral injury being applied to healthcare workers, where previously this was used to talk more about combat veterans. So when we think about soldiers, here's the description that we get for moral injury: perpetrating, failing to prevent, bearing witness to, or learning about acts that transgress deeply held moral beliefs and expectations. So when one thinks about being in combat, being on the front line, those are the things that are typically assigned to moral injury, and the exhaustion and the cynicism that the soldiers experience. So if we think about what's gone on in COVID-19 and why this is now a fit for healthcare workers, we're seeing people that are unable to provide high quality care, healing in the context of healthcare, and the death by 1,000 cuts. So again, this is back to a vicarious trauma response. This isn't the one heinous thing. It's the repeated, bearing witness to repeated traumas. And oftentimes with moral injury, it becomes a soul wound because we're doing things that are incongruent with who we are, with who we are as human beings and our relationship to society. So it's no accident that we're seeing a rise in suicide in healthcare workers. And in fact, physicians die by suicide twice as often as active duty military. And the reports that we're getting now, and I know everyone is familiar with what's out there, the lack of PPE and watching people die in isolation and that sort of thing, is really bringing up this notion of moral injury to healthcare workers. And I will talk in a bit about some things that we're doing with the Healthcare Heroes program to help our healthcare heroes on the front line address notions of moral injury. So who's at the greatest risk for these things? Those who are the most empathetic, those who do not see self-care as a priority, and those with a personal history of trauma. This is ironic because to me, these are the three things that always made me a very good clinician: the empathy and the ability to really connect. So this is why that self-care and being aware of our own responses is so critical. So why are we so impacted by some clients and not by others? What are our own specific vulnerabilities, and what are the things that can be exacerbated now in our COVID-19 world? So as we know, in the terms of countertransference, it really depends on our own life, the integration of our own life events. And we all know that this isn't a linear process. Our grief, our pain, our trauma is not linear. It ebbs and flows. So we get to be aware in our own mind and our own body of what's going on with us when we're with someone, because we all bring a past and a present to everything that we do. We have our belief systems. We have our social support systems, be they positive, be they negative. And also right now, they may be remote. We may be living in that panel virtual world where that's our support system. And that's okay. We simply have to be aware of how it's impacting us. And as we mentioned, our own history of trauma, illness, and integration. It's been really interesting to me to talk with people and to hear how their experience with their personal illnesses and their loved ones' illnesses really inform how they are responding to COVID-19. And also with grief. A lot of folks are telling me, I'm not afraid of the virus. I'm afraid of the grief that I might experience due to the virus. And so it's very important internally that we're tuned in with who we are and how we're experiencing things and our families and relationships. Also, economics. This is a huge one. This is a huge internal source factor. And we know right now, our country, we are going through a great deal of loss in terms of unemployment, in terms of people losing their portfolios. And I went through something on a much more, an abbreviated scale. In 2008 with the subprime crisis, I was doing a lot of work with land developers, and they basically lost everything. They ended up in residential treatment, and what we were doing is we were really working with them and their families to try to navigate their life from a completely different financial standpoint. This resulted in a lot of unhealthy coping strategies, divorce, and children who had no other way of being. And so it was an opportunity to rebuild, but the economic situation is going to be huge for us as clinicians. Was also interesting as I had a dear friend and colleague that was going through his own personal bankruptcy. And so to sit with a patient who was on the verge of divorce because they had to sell their lake house, it was very difficult for him to generate empathy for that. And so it's super important that we look at our own resentments and our own view around money, scarcity, abundance, and how that's informing us and what's going on. Because we're about to have a lot of economic complexities in front of us and potentially in our private lives, in our personal lives. Compassion fatigue is recognizable on the job by its effect of work performance, morale, and behaviors and relationships. How do we recognize it in our peers? How do we recognize it in ourselves? And how do we recognize it in our leaders? And how do we create a space where we can talk about it? So I believe the best way to identify compassion fatigue markers is the same way that we do this with our clients, by using a holistic model, mind, body, spirit. what's going on cognitively, emotionally, behaviorally, spiritually, somatically, and socially. I don't want to over-pathologize compassion fatigue, but it is important that we understand these things in order to grow ourselves and to support one another. So, cognitive markers. This is important as we talked about vicarious trauma and how it shifts our worldview because we are having covert cognitive changes. So in cognitive markers, we see intrusive thoughts and disturbing memories, lowered concentration, the reduced sense of safety, that we are not comfortable doing things that we would have previously done. Again, we are all experiencing this as we have our invisible threat, COVID-19. Emotional markers, powerlessness, anxiousness, anger, survivor's guilt, the emotional roller coaster, the feelings of being depleted, run down, being irritable, decreased self-esteem, and then behavioral markers, impatient, poor sleep, being jumpy or on edge, being accident prone, being rigid or inflexible, needing to do everything the same way, or using ineffective or harmful self-care practices or maladaptive coping strategy. And then spiritual markers, loss of hope, loss of purpose, being angry at God, questioning prior religious beliefs, being skeptical, and that loss of compassion that made us actually effective clinicians. Socially, this failure to get a life really, really resonates with clinicians with whom I've shared this presentation. And the trouble separating work from personal life, and loneliness, the isolation of not being able to connect. I've got a disclosure here that I struggle with this one myself, mainly in the, if we are going, my husband and I are socializing with people that are outside of behavioral health, and I listen to them talk about their lives, golf, tennis, what have you. And I find myself with this internal dialogue saying, oh my gosh, they're so trivial. We're out here saving the world, and listen to what they're talking about. And this is the sort of thing that not only negatively impacted my ability to connect with others, but also my relationship, as I would find myself texting my work colleagues or checking in on what's going on at the facility. And we didn't get invited to go out for a second dinner with a lot of people because simply put, not very good company unless I'm with my peers. And that's not okay. So this is something that really resonates in our field, that social marker, because that can lead to serious isolation and loneliness and increased personal conflicts. Then we have the somatic markers: shock, rapid heartbeat, sweating, aches and pains, dizziness, impaired immune system, and can actually be detrimental for our health. This impacts us in our work performance with decreased quality, quantity, low motivation, avoidance of tasks, setting perfectionistic standards, and obsessions about the details. To clinical supervisors out there, please note when your teams are avoiding tasks, both the big and the little, because that can show us that someone is struggling with compassion fatigue, and we get in there and support them as supervisors. Compassion fatigue can also have a significant impact on morale, the decrease in confidence, the loss of interest, the negative attitudes, detachment, and the demoralization that we spoke about with moral injury. and then negative impacts on behavior, increased exhaustion, irritability, irresponsibility, job changes, and maladaptive coping strategies or substance use. So never fear, it's not time to go out now to get out of the business or pursue a career at Trader Joe's. There's a light here, and there are wonderful things that we can do. We start with resiliency. Resilience is the person's inner ability to face fear and adversity with courage and will persevere and overcome. A couple of years ago, I was able to go through the Air Force leadership training on resilience, and the armed forces band together because they were seeing an increase in suicide, and they developed a provider resiliency training. And that's where I got a lot of really good tools, including an app that I will share with you. So, a little bit more on resiliency. I'm not here to pathologize again, and our resilience is our strength. And I want to think about who your resiliency role model is and what are the qualities of the people inspiring you. So as Courtney mentioned, I would be giving a chance in the middle of the presentation to poll on some things. And I want to ask you to stop for a moment and to think who your resiliency role model is and what are the qualities that that person inspires you with. And please shoot it in the question and we will talk about it a little bit. I love to do this because we don't want to label ourselves. We don't want to become victims. We're here because we want to leave the world a better place. Remember what brought you here? It's your ability to relate, to connect, to empathize. You're here because you care about others and because you're basically a badass. Now let's talk about some of those people in our lives that have inspired us to be that way so that we can draw on those qualities when we're feeling a bit shaky. So is there anyone that would like to share in the question tab their resiliency role model? Oh, Olivia Mead, CEO of Yoga Shield. I have met her. She's fabulous. Hillary Clinton, there we go. That is a gritty woman. Very resilient. My grandmother. My mom. My father. My boss. She really takes the time to make sure staff is mentally healthy. She's able to work hard, serve clients, and take care of herself. Dr. Sarah Scarborough. Another mom. I love it. Michelle Obama. My father, Steve Gleason, Nelson Mandela. Could someone shoot some words to me about them? What is it about the person? Humble, self-aware, and working on herself. Accepting human fears. Love it. Kind. Brene Brown. Redefining her happiness and getting out of an unhealthy relationship. Sets boundaries. Yay, love it. Vulnerable. Compassionate. Okay. Never giving up. Still smiling. Thank you for these. These are beautiful. And I think it's really helpful to think about folks out there that are resilient and to draw our inspiration from them. So I'm going to give you some tools to continue to build our own resiliency. And I love this motto. here we go. How do we build it? So the ability to self-soothe and self-confront at the same time, simultaneously, in a stressful situation. So when I first learned about this, I thought, are you kidding me? It's like tapping your head and rubbing your belly in circles. It's not easy to do. But when I worked on it, I realized that when we are able to self-soothe, then we can get some self-confrontation going on, and the self-talk turns into something positive, a mantra that steers us, that drives us on during times of stress. So think about this. Self-soothing, it's when we deliberately relax. We regulate by breathing, meditating, orienting, grounding. That's self-talk. My favorite, all is well, in a rhythm. Self-confrontation is a little bit trickier. This is the process of assessing our own anxiety and examining what might be learned from the situation. It's not easy to do in the moment, but it's imperative so that we can grow. And this is where, while we're soothing, we're able to ask ourselves, what's going on here? Why am I so anxious? What am I trying to prove? Who am I trying to impress? Am I trying to fix something or someone? Am I depending on someone else to validate my sense of worth? And what's the growth in this situation? Another tell on myself here is that I maintained a private practice 2 hours away for years while I was in Tucson in a variety of positions. And I did this because I really thought that I was the only one that could help those people, because I was the best therapist in all of America. And I really had to call myself out on my you-know-what, do some heavy self-confrontation and say, that is not accurate. You're depending on, it isn't even healthy, and what you need to do is refer those folks and focus on what you're doing. So again, self-confrontation. When we don't confront ourselves, when we're only able to self-soothe, we tend to be avoidant folks. We withdraw, being demanding, maybe driven by emotion, and that's where we're vulnerable for the maladaptive coping skills of overeating, substance use disorder. Become the victim. When we can only self-confront, when we're rough on ourselves, when we're negative, we don't grow. We fail to see the growth out of any negative situation, and you certainly become the one that no one wants to be around. The chronic stressed out person, the one that's the negative Nancy, the agony Angie, the one that's really quite off-putting with their confrontation and negativity. So that's why it's so essential that we be able to master the art of self-confrontation and self-soothing. And that's when we can build some resiliency. Another slide that I pulled that I wanted to be sure that we capture on as we continue to work through building resilience is this quick slide about a work system. So we've got the provider, that's us, in the center. We've got the system off to the left. We've got the patient, and then we've got our own trauma, our own story, the things that we are bringing with us into the environment and our exposure to various types of trauma. So this focus on the work system also brings in something on the right. That's that yellow circle of our fellow workers. The work system and the fellow workers balance out what we are experiencing with our patients and with our own history. And this is where we can introduce another critical component to building our relations, to building our resilience, our relationship with our fellow workers, our colleagues, and the compassion satisfaction. This, for me, is the light at the end of the tunnel. This is a place where there's a great deal of inspiration to be had. At Sierra Tucson, we just had a therapist retire after 30 years of working here. She'd been a primary therapist. She had been a family therapist for many years. And so she obviously had the compassion satisfaction that helped her in our world, helping others. And what they like to say in our family department, that our family therapists go where angels fear to tread. And I always like that. Her name is Michelle. Michelle, thank you for your 30 years with us. We miss you and are so incredibly happy. So that's some compassion satisfaction right there for you. What is compassion satisfaction? It's the positive aspect of helping others. It's the pleasure, the satisfaction derived from working in a healthy caregiving system. It's how we feel about our friends, our coworkers. Can we count on them? And when we lose this, when we are too depleted, too exhausted, too cynical to show up for our friends and for our coworkers, or to glean the healing from our work, then that's when we're really in trouble. This compassion satisfaction can be impacted by the system, and it can be negatively impacted by a lot of different things, as well as built up by our beliefs about ourselves and our altruism. So this becomes important to understand where we are with our compassion satisfaction, our burnout, and our secondary traumatic stress. There is an assessment called the Professional Quality of Life, proqual.org, and it takes 3 good psychometric properties, 3 subscales of it: compassion satisfaction, burnout, and secondary traumatic stress. And what it does is it gives you a score in each one of those areas, and then it gives you a total score to let you know where you are with respect to your compassion fatigue. It's an extremely interesting and important assessment to do. And this next slide, and you can do it with the link that I provided with paper and pencil, but also we can do it with an app that I have. It is www.iTunes, apple.com. And what this does, it's a provider resilience phone app. And this was developed by the Department of Defense. I told you that they are really committed to the resiliency movement right now. And this is out there. It can be easily downloaded. And what we do with this is that we're able to do the ProQual. And the ProQual gives you, I'm going to use my mouse here. I take my ProQual every 30 days. And what this gives me is my score in my compassion satisfaction, my score in my burnout, and my average score for secondary traumatic stress. It also gives you your overall resilience rating, and it shows you where you are in that, and it tells you, it keeps track of your time since your last vacation, and it gives you a vacation clock. And then it also gives you some really cool resilience builders and killers. And it's kind of rough language. It's from the military. So we've got resilience builders. It gives you the ones, for instance, it's got, did you take a short walk? Did you perform at-desk stretching? Those kind, have you taken a day off within the last 60? And so we really get to test on ourselves. Have you laughed at something today? And you get to add your own, you get to add your own resilience builder, and then it gives you your resilience killers. And so you're able to see how you're doing with that. It also gives you some tools on the bottom where you can have, there's meditation cards, some quick physical exercises, value cards, things that you can do. I highly, highly recommend that you download this and use it in your work group. It's extremely effective. It gets us quickly into the solution, and it holds us accountable for how we're taking care of ourselves. So building provider resilience. Another thing that is very important is that we model the same things that we tell our clients: physical, mental, emotional, and spiritual renewal. I'm going to go quickly through these resilience skill builders. They are things that we are all aware of. If anyone needs further information, please let me know, but in the interest of time, I'm going to scoot through them. Self-regulation, our body awareness. Where is the regulation coming up for us? Where is the dysregulation, I should say, coming up for us? Intentionality. What's our why? Why are we doing this? Are we attached to our mission? Are we living by our principles? Are we able to tolerate some pain in order for our own growth? What's our perceptual maturation? Are we able to be resilient to judgment by clients and peers? Are we able to roll with things, or are we excessively prickly? Those are things that we get to look at building our perceptual maturation. This balance of potency and humility. I love this one because, as we've heard and I was just reading off a few of the resiliency role models, the humility is something that really comes up whenever I've done this talk, that resiliency role models are humble. So being able to balance that potency and humility is extremely important. Connection and support. Empower a few to confront you. I have a few people here that will tell me when I'm getting too intense, they will tell me when to turn it down a notch, tell me exactly what's going on, and that's okay. We also have the ability to tell on ourselves and to create and share the narrative of our experience with one another so we know what we're dealing with. In terms of self-care, something that I want to be sure to spend a bit of time on, because I think it would be remiss if we don't touch on the ethics of self-care, especially with all the discussion of moral injury and things that really offend who we are, for lack of a better way to say it. I want to talk about ethics of self-care and taking the time to check in so that our self-care is active, it's deliberate, and it's creative. And by doing that, we fulfill our ethical and also our legal responsibilities. So what do I mean by self-care as a good defense? I've seen time and time again when behavioral health professionals end up in an ethical quandary or a board complaint, it's often because they're exhausted and they unwillingly slid too far down a slippery slope, or they were struggling with their own depression, and it wasn't as much of being aloof or ignorant to the ethics, to the laws or practice standards. It's because of the compassion fatigue and that exhaustion. And it's one of the most common complaints, a lack of boundary to professional boards. And when we're taking good care of ourselves, this is the best way to proactively manage our own risk. So to look at professional self-regulation, we look at self-care that's guided by a series of aspirational ethical virtues that are articulated through a variety of ethical codes. These are words that we don't often use in our day-to-day communication, but they are worth chatting about briefly. Autonomy, beneficence, non-malfeasance, justice, fidelity, and veracity. Autonomy, fostering the right to control the direction of one's life. This can be difficult with a vulnerable population. However, autonomy is an ethical tenet. Beneficence, the belief that the person in power is attempting to improve the other's situation through delivery of professional service, working for the good of the individual and society. Justice should be evident wherever people are seeking help from others because of their circumstances. Fidelity, being able to honor our commitment, our promises, including one's responsibilities of trust in professional relationships. To gain that trust, we've got their trust that we will always operate in their best interest. I look at this with therapists throughout the years, and I see them when they're constantly late for appointments, when they cut the appointment 10 minutes short. I know that there is something going on. There's something going on with them. And so again, the keeping our own commitments can be little or it can be big. Veracity, dealing truthfully with individuals with whom we come into professional contact. The ethical pitfalls when we are struggling and we may erroneously violate one of these things. Boundaries. We know that boundaries are flexible, they become squishy, they become rigid. Be sure that you've got someone in your inner circle that can check in with you on your boundaries. Multiple relationships, dual relationships, these can be tricky to navigate, especially when we're exhausted. Social interactions, non-sexual touch, and self-disclosure, as well as practicing outside of our area of competence. Self-disclosure is the one that I've seen with therapists that are struggling probably the most often, and it's good to be mindful of that. Again, if we run into a situation that is challenging us with our ethical code, with who we are as a professional, if you're starting to experience the soul crush, let somebody know. So as an organization, how do we make sure that we are not fueling the flame of burnout, and God forbid that we are not creating an environment of moral injury? I have found that the best way to do this is to commit to being a trauma-informed organization. What that means is communication, collaboration, and transparency. By creating that safe environment, we automatically build relationships, focusing on and teaching emotional regulation. It's very interesting to me that when we have a trauma-informed organization, when it's well done, then what happens is not only do we have an organization that's built on the tenets of servant leadership, but we also have built-in protective factors so that we are creating peer and family support, so that not only does our workplace become a place where we feel like family, but we know each other's family because we've had events, because we communicate, so that we have that built-in protective factors, that we have shared hobbies, that we have an environment where we're creating the ability to solve problems, an innovative, creative, non-robotic environment. And again, this becomes problem solving, becomes a protective factor, as well as that ability to connect. Those are all built by the culture of safety and being trauma-informed. True story, when the stay-at-home order came out in Arizona, and obviously we have 3 levels of care here in Tucson, And so we need our essential workers here on campus with us to support our patients. I had so many people come to see me and say, I don't want to stay at home. I want to be at work. I feel better when I'm at work, and that's my family. Work is my safe place. And you know what? That made me feel very good that we are acting as a trauma-informed organization, creating that safe place. So on the other side of it, you know, no environment is perfect and no situation is perfect. And if we are experiencing moral injury, some things that I really believe are important is ease up. Allow our teams, allow one another to plan a bit of a lighter schedule, to rebound from a tough case, from a large group. Allow time to ease up. Truly, genuinely check in on each other. Truly listen, provide support with public support and recognition, and be able to tolerate negative feedback without defensiveness. And probably most importantly, begin to embrace the new normal. We all can't pretend that this thing didn't happen, this thing isn't happening. And so to embrace the new normal and learn how to grow from it, rather than to just dismiss or minimize what's happened. Because if someone is experiencing vicarious trauma, if they are experiencing moral injury, the last thing we want to know is how try to gloss over anything. Some other quick things that we can do in an organization is to give credit and reward a job well done, dignity and respect, be available to talk. Leaders at all levels acknowledge our stress and to set good examples of self-care. And so those are some of the things organizationally that we can do. In terms of being a clinician, some things that I have seen very effective with compassion fatigue is to set up a healing group, to say, okay, right now what we're going to do is we're going to process our stories. We are going to identify a small group of us, and we're going to be able to talk freely and openly about how our work has impacted us, and to journal our narrative of the positives and the negatives that have happened to us in our work, to be able to share that, and then to be able to plan how are we going to support one another and to support ourselves. Because as we know, things are becoming more complicated, and it's more important than ever that we utilize some of these tools. The other thing that I wanted to do before we switch to questions is to just ask to journal about some of the wonderful ways that your work has impacted you and has impacted the people that love you. And I believe if you sit with your journal and you think about that, it will be a true gift to know that what this work has done in your life and what it's meant into the lives of others. So with that, I thank you for all that you do, and I ask you to take care of yourself and each other. So let's go through some questions. I'm loving these resiliency role models. This is beautiful. I also like how many moms we've got here. Very timely with Mother's Day. Okay, would it be possible for you to come and give this talk with my staff? Yes, as soon as I'm allowed to travel again. I love to give this talk. Speaking of journaling, Mental Health of Virginia posts a journal prompt every Monday, Wednesday, and Friday. Some are serious, some are silly. Wonderful. How could this information be transferred over into the first responder community? I actually have an adaptation of this presentation that I've done for first responders. So it absolutely can be adapted to be less clinical, less geared at therapists, and more geared toward first responders. Obviously, we talk more about the trauma, the secondary trauma and vicarious trauma itself, and also impact on family. Do I recommend that we assess for compassion fatigue every month? I do. I take the ProQual every single month, and I don't think it's ever been time wasted. I've really learned some important things about it. The challenge of finding the best therapist for the therapist. That is so true. Absolutely. Can I give us some example stories of self-confrontation? I gave you the one with the situation where I confronted myself because I felt I really overstated my own value, and I realized that I did that because I was getting my value from being a therapist. I had a graduate professor tell me years ago, don't fall in love with being a therapist, and I felt like I had gone off the rail a little bit in that, and that was a self-confrontation that I could refer a patient out and it would be just fine. Another example of self-confrontation is in the workplace. If we find that in a very stressful situation, we're being unpleasant, that we are not taking the other person's point of view. You know, that whole what's it like to be you question, that to me is my best self-confrontation. When I'm interacting with someone professionally, I pause and I think, what's it like to be them? Because right now I'm coming from a place of self rather than what it's like to be them. So that's an example of some self-confrontations that I have done. Is there a way to use the ProQual outside of a social work realm, thinking for an outside organization? I think so. We would need to do some, I know that it was designed for the helping profession, but I feel like it's something we could definitely look into. Okay. In a private practice or small setting, can I speak to the pitfalls of compassion fatigue? Yes. And I believe it's the isolation. And that to me is the greatest pitfall of a private practice. 8 hours of story or 6 hours of story without the interaction. And if we think about it, we become that blank page on which someone tells their story, and that can have a variety of different ramifications. So for private practitioners, I believe it's essential that we stay in the world and communicating with others. How to deal with relentless documentations, changes, and paperwork, which is burning us out. You know that the struggle is real. There is with insurance companies. I know we struggle with that at Sierra Tucson as well, and we are always looking at ways for new and more efficient ways to do documentation. Is there any data on vicarious trauma being increased or decreased when providers are using telehealth? That's such a great question. Not yet, not that I've been able to see. And as we know, in the past 2 months, the use of telehealth has just increased exponentially. So the jury is out in terms of efficacy and also the compassion fatigue around it. Will you be receiving a copy of the PowerPoint? Yes. What is the info for the professional quality of life? I included the app. I included the link on one of the slides. I'm seeing such a strong need for some version of this for our public school educators. I'm working on an e-learning module. Are there resources you recommend for educators, especially now when school was the safest place and our students are not there? Rhonda, please email me privately and I can tell you some of the things that I found. Diverse interests contribute to the balance. Absolutely. Could you use the Resiliency app with students? I think it depends on the age of them, but absolutely. I'm the owner clinical director of my business, so the buck stops here as far as no others to provide support. Any ideas of resources for me to support? That is another one that we can talk, Stephanie, offline. I love to talk about that. If you want to give me a shout via email, we can set something up. Do we use the app with impaired professionals and clients? No, I have not. That certainly could work, though. That's a great idea. Can this be adapted to medical students and residents? Absolutely. Absolutely. I believe that would be a very quick adaptation. All right. I believe that our time is up. I thank you all very much for being with us today. And my email is available. If there's any more questions or any more resources, please let me know. Thank you.